are going to really take advantage today of the fact that we have three folks here that I think work well together, but are also working in different silos and have a conversation that's focused around working together and how to tackle these issues together. We would love to have, and we've got them in the hot seat, take advantage of this, and we're going to do questions a little bit differently. We would love to have you writing down questions on cards and handing those to Liesl and Andy, so they'll be walking around. And in particular, follow-up questions would be fantastic, and we'll see how many we can get to at the end. It may not be a whole lot. So they've had some of the questions in advance. One of the first questions, and I'm actually going to do the second question first here, because I thought it was a great opportunity when Rob Bohl, our keynote speaker from earlier, started talking about data and all the amount of data that is out there in the world and how it's growing so incredibly fast. And we are struggling just to try to coordinate and understand all of that information that's out there. And that is one of the really critical problems that health transformation is dealing with. And so the question that we'd love to have you first start with is, how are your organizations approaching so we have data in all these different entities. Ryan Fisher talked about how there's 24 entities out there with different kinds of data. How do we coordinate and better understand the data and use that data to transform health and really focus on the right kinds of health outcomes and really truly improve health outcomes? How do we have data-driven health outcomes that will really truly make the most impact? And what are your organizations doing to help coordinate and make sure that we're as effective as possible there? And so we have 3 minutes. We're going to try to keep your answers to 3 minutes, and we'll do a little follow-up if we can.
3 minutes.
Okay.
Glad to be here. I, again, am the Director of Oregon Housing and Community Services, and I don't have a good answer. What I can share is I think this is the right number. There's different people give me different numbers. I have 21 different data systems at Oregon Housing and Community Services, and they don't talk to each other. And so data is a huge problem. We collect data from property owners that we've helped finance their apartment buildings, for example. We collect tenant data. We ask our partners who do human service related work out in the field on our behalf and with our dollars.
Your mic is starting to fade.
Oops, sorry. Is that any better? I could just talk.
I've got all your juice. You can use this too. Mine use this.
All right. So data is a real issue. I think the governor's budget and the governor's 10-year plan certainly asks us to think about and go much deeper than we have in the past in thinking about integrating systems, both sort of human systems and human resource systems, but also data systems as well. I think we're beginning to have some of those conversations. I think Jim is probably farther along, for sure farther along than me. And so I see it as an issue, and I agree it's something we ought to work on.
So it is a huge issue, and it's not just organization, it's within every organization. We have 14 different ways to write a check. We have multiple case management systems. We have 2 different eligibility systems for Medicaid alone. And so it's a huge problem. And the reason we have that problem is that all of these systems were built in silos by all the way from the federal government on down. Because Medicaid has its own thing it pays for, and nobody wanted to pay for anybody else. And so we're living with that legacy today. I think the things that we're doing right now, we have one unit within, actually it's a shared service between OHA and DHS that has been building a data set that cuts across programs, at least for research purposes. We can gather some information that way. That unit is also reaching out to other departments and building data sets even across agencies within state government. And that gets us somewhere, at least. But I think ultimately the modernization program and the exchange program that OHA and DHS are building as essentially agreeing upon a common platform for how we would store data, and we're working on an active data plan for the agency to bring it onto that common platform. And that's the way of the future. Now, we're just in the beginning stages of this. We're just starting in the next year or so to start rolling stuff out of this, but that, we hope, is the foundation for a much more rational way of managing data within the department. We both formed units. We call ours the Office of Business Intelligence. I don't know what you're calling yours, I forgot. But
we can't talk.
The healthcare
business
analytics.
intelligence.
No, it's a healthcare analytics unit, and with people in charge, essentially the data masters for the two agencies, and they meet on a regular basis trying to build a data strategy for the two agencies. And so we know it's a problem. It's a huge, huge problem, and it's going to take a long time. Oh, I don't know what's a long time in this world, but now that I'm 64, but it will take some time to do it and to do it right with the fracture we have now. Anyway.
So I'm going to flip it around
Yeah.
and take a different approach. When I read this question, I wondered whether that was a question for you and not for me. And I'll tell you why. You know, you think about this. I think this is a hugely important question. Data is power. And actually, do you want to have all the data centralized? I'm not sure. I actually think our job is the opposite in many ways. It's actually about data liberation. It really is. And actually, that's a big piece of what we're trying to work on, is we have these, Margaret said 21, I don't know how many data sets we have, hundreds. And I think that actually our job is to liberate them, is to make them available to the public, and look for innovative ways that the public and community-based organizations are going to use data and information. I'm not sure, when I think about this, that the best use of data and information is to have it all centralized. Think about it around healthcare information. Do you want me having all your healthcare information, or do you want your doctor having healthcare information? When you think about community services and all these, all the variety of information, should that be something that is centralized at in Salem, or should that be information that's available at a community level? It's a really interesting question. I'm not trying to be facetious about it. I think we've got a lot of work to do in terms of integrating and coordinating the data at a state level and between our agencies. But I think ultimately the true test of data and information is going to be the power and the usability and the coordination at the local community level, so that every one of you in the audience can actually raise your hand and say, yes, we have all the data and information that we need to help empower some of this. And it's just a different way of thinking about it. I think we spend a lot of time and effort and expense, and we have a huge track record both in the public and the private sectors in incredible promises about data and information, and about new data systems that, you know, someone wants to sell you a program that's going to change the world. And I think we are all living the failures of a lot of that. And so I really get back to, I'd love to get the data out to everybody here. And you know, my sense is that a lot of community organizations are going to figure this out better than the state will.
I think that's a helpful vision, and I think it actually kind of matches some of the conversations we had earlier today, that there is a ton of expertise in this room, and that folks have answers and solutions out there. It's hard to, so how does that develop? I mean, how does it, you know, what's a timeline, or what's a process, or, you know, how is it going to come to fruition that that information will be shareable and actually used for that outcomes, you know, health and those health outcomes. That's still, it's sort of a, you know, as the Michael from The Office, it's hard to grasp and see how that is going to develop.
You know, I don't know how it's been developed. I think that, I think the more that we get data and information out to communities and can provide, I think, support for innovative ways of using that data and information, that's really going to be how it's going to happen. I'm not so sure it's going to happen. I think, you know, embedded in this is, you know, when we talk about all this interoperability and all these things, I think in many ways that, to me, starts to speak to large data warehouses and large systems, which I think we've got about 10 years of experience of seeing that hasn't worked really well. And so how's it going to happen? I don't know. I think it's going to happen community by community. I think it's going to happen coalition by coalition. And I think our job, perhaps, as government is to more stimulate that local innovation rather than sort of create the big data warehouse and have everybody say, Mother, may I have this and may I have that? And that's what we do now, and I just don't see it as being extremely effective.
Because I agree with Bruce that the whole reason that if you're going to be outcome driven, which we're committed to, then the whole reason you gather the data is to get it to the professional on the front line, or the group of professionals that are wrapping services around a child or a family or a community, is to get the information they need to do their work. That's the fundamental principle of, I'm not talking of just the notion of transformation in general in the private sector as well in the public sector, is to push that decision making out into the community, into the field, and especially with our services, which are provided mostly by people outside that are not our employees, is to push that information out and give them the information they need in a way that they can use it to give the service that's appropriate in the time and the place and make the right decision. That's the whole reason of doing this. I do think there is an infrastructure piece to that we have to deliver on, and getting data in a common format to where you can manage. It's all a management issue. How do you manage this data so the right people get it? And that's extremely difficult to do when it's in 25 or 30 or 100 different systems. You don't have the resources to manage it that way. And you make way too many mistakes. It needs to be on a firmer infrastructure in order for you to do that. And so I think there's a piece to that. I think there's also a piece, as Bruce is saying, to the local management of data. We don't have to own all the data in Salem in order for this to work. And we have to find ways of providing it, not just through some sort of central system.
Go ahead, since it's on topic here.
Great, thank you. So I am Rachel Post with Central City Concerns. So I'm thinking about this because I'm participating in a lot of processes now that relate to the Governor's Employment Initiative Work Group, the Early Learning Council, the TANF, work around TANF, working with Health Share Oregon, and thinking about, you know, the objectives of the AAA and your responsibility to perform for CMS based upon, you know, the
Our responsibility.
our responsibility. I think the state's ultimately to be able to exhibit what did that produce, operationalize, measure, what did you get for that money. So I guess, you know, when I'm in these forums and I'm thinking about how each of these systems intersect with each other to provide integrated, efficient, quality care across multiple funding streams, you know, I imagine maybe and it's, you know, grandiose, but that the state has a vision for how you're going to be able to track that. And so I appreciate your saying, you know, giving charging the community with the responsibility to look at the data and form coalitions to figure out how we're gonna do that. But I guess, is there any sort of more information you can share about sort of how do you know if we are meeting, you know, the objectives of the
I think it's a great question. Part of this is, how do we deal with the data we have? And then part of it is, what data do we want in terms of outcomes? We've developed a number of outcomes, and there's 40 metrics on the healthcare side that we're going to be responsible to CMS about. I think we actually know how that can be measured and how that data can be collected. What's been a struggle is I'm not so certain those are the right measures and metrics of health of a community. And I think one of our challenges as a state and as everybody in this room is, what are the 10 best ways to measure health? I can tell you the ways that we're measuring it for CMS, but I can tell you that everybody that was involved in that process, and there's some people in here who have been very frustrated by it, because they've been very traditional measures about diabetes control and issues around chronic illness, and really not getting at some of those core questions. So I think we've got to develop, one of these questions was chicken and egg, and actually this is the chicken and egg question. I think that before you think about the data, you've got to think about what it is you want to measure, and then what data and information do you need to really be clear that you're measuring that and you can track that across communities and across populations.
The enthusiasm and understanding about how housing really helps make people's lives healthier. And I'd love to hear a little bit about, what is it that housing folks need to be doing to really make those healthcare connections. There are some, I think, great examples, at least one great example of how some of this has been done in Oregon, and then what can the healthcare community and what needs to happen in there, and if there's a human service component too, that'd be great.
Well, I'll take a crack at that. And I'll harken back again to the 10-year plan, and we are really called to think differently about how we deliver our programs, to integrate, to get out of our agency silos and make different decisions and set different policy priorities. Some of you may know that in the governor's budget, my agency is actually asked very specifically and very quickly to come up with a different service delivery model, because we're running out of money to do things the way we're doing them today. And so the governor's budget actually gives my agency 1 year of funding and says, come back in the February short session 14 with some plan for how would we deliver housing finance and community services programs differently in this state. Well, that's pretty scary on one level. On another level, it's actually a really huge opportunity for us to think differently about what we're doing, what our dollars are for, and how do we get the most money out to low-income Oregonians who need it. One of the things that's been really interesting to me is the way our decisions get made and the way policy advice comes to my agency. Is I have 6 statutorily named advisory bodies who tell me everything about ending homelessness to farm worker housing to hunger. And all of those are really compelling and good ideas and very thoughtful people who make up those groups and come talk to us about what our priorities ought to be. But it's pretty hard to have a cohesive strategy when you got 6 bodies named in statute telling you what your priorities are. So I think for my agency, and at this moment in time, there's a real opportunity for us to think differently about governance, about policy setting, about alignment, and about how, if we're going to use a tax credit to build an apartment building, and it's a scarce resource and there's not enough to go around, which apartment building should we put that money into? And I think this is a real opportunity for me to work with my colleagues in state government to think differently about those priorities. And so, you know, more to come on that, but I think there's good work ahead. So,
I think the real challenge, and we're just at the beginning of this, is how you transition from really the model that we've delivered health and human services in the past to a different model that really is, I think the vision is something that's community-based, something that's focusing on outcomes, and that looks at how we put together our resources and use them more wisely. But that's going to be a transition. And we're going to have to figure out how we work through that. And I think how that happens is going to depend on the success of a variety of different community organizations. I don't think anyone knows exactly the way to do this. But a piece of this is going to be certainly when it comes to a variety of healthcare issues, housing is an important determinant of that. Certainly one of the biggest issues for individuals with mental health and substance abuse problems. But does that mean that suddenly everybody on the Oregon Health Plan tomorrow is going to be able to get their rent paid? Does that mean that everybody gets, everybody in this room has probably heard the governor's air conditioner story about 4 or 5 times now. And it's a great story, but the question is, I use it all the time. The question is, does that now mean everybody on the Oregon Health Plan gets an air conditioner? I've been asked that in a lot of different places, and I think we've got to figure out how are we suddenly saying that a huge amount of dollars that have gone into social programs aren't needed now, and we're going to pay for housing assistance and air conditioners and transportation dollars and job training all out of the healthcare budget? And actually now DHS doesn't have to do any of that. Margaret doesn't have to do any of that. No,
I can retire again.
That's not what we're saying, and I think the issue is we're starting by putting together some of these healthcare organizations with a global budget, but at some point, how do you manage and govern other kinds of funding and support in that kind of a model? I'm not certain a medical model is the right way to do that. And we're creating these coordinated care organizations that initially are formed on a medical model, but if we're going to truly change care, we've got to move to a more social model. So do we need to put together more social organizations? Probably, but that's going to be a transition for us as a state, and quite frankly, for everybody as I look across the room in this room.
So when I think about it on the human services side, I think of it as the problem squared. And what I mean by that is that if you look at our mission and you look at the outcome areas in the governor's budget, so you look at safety, you look at healthy people, at a healthy economy, at education, what our mission is to get all of those things for a particular group of people that struggle in our society to get those things. And so, in effect, the need for coordination, the need for the kind of outcome-based interaction that we've been talking about sort of doubles. We're a player in, as Bruce was saying, we're a player in all of those outcome areas. And whether or not that service delivery comes through that kind of model in that particular area and a different kind of model in the education, I mean, how that works and how we interact and how is a sort of, like I say, a squared problem. It adds another dimension to the size of the problem. And so And so it's something we really are committed to. We really are committed that this is the way that we have to act and we have to operate, whether it's the differential response kinds of things we're doing in child welfare or some of the other things we're doing in other programs. That's what it's going to take with that population in order to get the outcomes we want. The education system can't educate kids that are disadvantaged by themselves.
With the Bud Clark comments, which I think has been a great model, when the healthcare providers were able to determine who the most vulnerable folks were that needed that housing, and they were able to place those folks in that housing, the commitment for them to stay engaged with those populations has been really tremendous. And from their side, it wasn't extra, it was an extra resource they were getting, and that commitment was pretty easy for them to make. So this next question is, I'm going to take an audience question here. This is for Bruce and Jim, and Margaret, you're welcome to chime in. What opportunities do you see to better coordinate long-term care and acute care and rehab?
Oh, I think this is, I think we have an incredible opportunity to do that. We very much created very separate systems in this state. We've got a healthcare system, we've got long-term care and rehab and all those services, which quite frankly have been operated and managed in very segmented ways. And I think much as with housing and much as with many of the things that we see ahead of us, I think we've got a great opportunity to better integrate and coordinate them. I think that our state's long-term care system is really in many ways a great model to aspire to, because we have in many ways created a social model. We took what was an institutionalized system and put it out into the community and into home. It focuses on independence. And it's sort of in many ways exactly what we'd like to see happen in the healthcare system. I think that the issue is that they can't happen apart from each other. They've got to be better integrated and coordinated. And that's what we've got to work towards, I think, over the next 3-4 years.
So I think the thing I would add to that is, beyond, yes, there's a huge opportunity, is that the struggle is how to do it. And it's a different way of acting. There's a cultural component and learned behaviors that are true of all of us, whether we work for state government or a provider or whoever we work for. There's a cultural aspect of it that has to change with experience. But there's also, and this again comes out of the whole theory of transformation. The whole notion is that you can't figure this out from above. This is not a top-down decision-making process. The wisdom is out there, and you push and you create a framework and a structure for pushing those decisions out and the metrics so that you can reach common agreement about how well your processes are working. And then you figure it out, and that the wisdom of all of us is much better than the wisdom of any one of us. And that I mean, this is not a new concept or a revolutionary one in the sense of that it hasn't worked before. But I think in government, at the scale we're talking about, it is, and especially when we get communities involved in it. But to me, that's the answer isn't in Bruce or me, it is out there, just as he was saying.
And just think about it. Right now, if your outcome, if you have a long-term care facility, the healthcare side of the component, it really isn't judged or held accountable for someone's ability to actually remain there and live there and not end up in a hospital. If there actually was that accountability, you would see the healthcare system actually function very differently. They would perhaps put a nurse practitioner out or a nurse in a long-term care facility to actually see people and see them on site and take care of their medical problems before they end up in a hospital. But right now, there's no integration of that, and that's not what the healthcare system's held accountable to. No one's held accountable towards that sort of health outcome. So I think that's really how you start to change how things are organized, run, and how they begin to be integrated.
So we have time for one last question. With success come new challenges, and we have successfully identified a strategy to ensure a tremendous amount of our population that has been uninsured. We still will have 7 to 9, projections are that 7 to 9% of the population will remain uninsured. What can we all collectively be doing to make sure that we are not leaving that population behind, that we are identifying ways to integrate those other folks into healthcare transformation?
Yeah, well,
It's 4 o'clock.
We've still got 3 minutes.
you know, it's an interesting question because I think you can look at it from a number of different perspectives. When you look at who's going to remain uninsured, I mean, there's a group of people who are voluntarily going to remain uninsured. They have, they're going to be people with the financial means to have access to health insurance, and they're going to choose not to be insured. That's probably about half of the people who will remain uninsured after health reform. I think there's another part of the population who are going to have less means that we should all be concerned about. And I think that population, in my mind, breaks down in 2 ways. One important group of that are a group of people who are non-citizens. And that's going to be a huge political and social movement to be certain that those people are included in the tent in this state. And I think we all need to work towards that. Then there's another group who I think are people who we all also need to work on, who are going to be people who are, we need to bring in and work to bring in through outreach. They're individuals who don't trust many of our programs and organizations. There's services and things that we provide that aren't culturally appropriate, and that they would be much more interested in accessing if we built something different. So I think it's going to be a lot of different approaches. I think it's going to be a political approach around non-citizens. I think it's going to be building the kinds of programs, systems, and outreach that's going to bring the rest of some of those people in. And then I think that there's a group of people who are going to, you know, working individuals who are going to choose to self-insure in many ways. And I think it's going to be up to us to educate them in a variety of ways and bring them into our tent.
Great. So, any quick closing comments? Any advice for us in what we can be doing as a coalition that would be helpful in your efforts in moving forward? Any questions you want us to try to tackle in our future meetings? Closing comments.
Well, I would just underscore that, you know, again, my agency and the programs we operate we're gonna put them under the microscope, and we're gonna have some good community engagement opportunities. And I will actually look forward to staying in touch with you as a coalition and as individual members to help me think about, what are the guideposts we ought to be thinking about as we work to transform the programs that we're responsible for at the moment. So that's a thing for stay plugged into my process, which I haven't invented it yet, so stay tuned on that.
But you will very quickly.
My 2 words are constructive engagement. I think that we're, and I say this honestly, not Pollyannish, I think we're really at the very beginning of creating something very effective, very new, and very special in this state. But we're certainly around healthcare. But we are really in our infancy. We've got these coordinated care organizations. The oldest one is 127 days old. And the youngest is, I believe, 35 days old. And in a system that has decades of dysfunction and entrenchment in it. And it's going to take a while to sort of turn this around. And I think it's going to take to me, it's going to take the real constructive engagement of everybody in this room. Because if we're going to make this whole CCO work, it's going to be about the engagement of all of the people in this room. I can tell you all the doctors and hospitals are really engaged. I don't need to engage them in a lot of ways. What we do need to do is create a new, much more socially focused and community focused model of healthcare. And that's where you come in. So be involved, be engaged, and understand that we're in the beginning and we've really got to move this forward.
Yeah,
I gotta run, I'm sorry.
And I would say, what we said, and add to that, it's basically the same thing that Margaret and I were told when they put us on the improving government team, which is really a huge change for state government, and it's to participate and take an enterprise view. And to tell agencies to do that, I don't know, I've been around state government in Oregon a long time, I don't know that I ever heard that. And that's to think that that's such a huge revolution, even within something as insular as state government. Imagine doing that across the whole state. So participate, do what you're doing, participate.
So unfortunately, we have a lot of questions here that we couldn't get to, but I'm going to invite Liesl and Andy to come back up, and they're going to close things out, but I'm also going to give them these cards in hopes that they will use these and find ways to sort of further